Hello and good evening. My name's Alvin. I'm the medical legal lead at Mind the Bleep. Thank you very much to all of you for joining today's webinar presented by Dr. Ranjan. Today's webinar will be on research ethics, of which Dr. Ranjan will talk about in detail. So before that, as with all our previous webinars, a few ground rules. So if you have any questions, so this functions like a YouTube Live, so please comment in the YouTube Live comments section, and then we'll be able to see it, and at an opportune time, I'll be able to ask Dr. Ranjan. As well as with regards to certificates and so on, there'll be a QR code that I'll be putting up at the end that you can scan. So please fill that in, as all the feedback that we receive is very useful to improving our webinars and so on. So we'll give it a few seconds, just make sure everyone's joined. Okay, that should be fine. All right, so Dr. Ranjan, if you'd like to take the stage.
Oh, thank you so much for the introduction, Alvin. My name's Aditi Ranjan. I'm an academic teaching fellow and also a trust grade doctor. So I'll be doing my presentation on research ethics. So I'm just going to turn my camera off and start sharing the screen. I'll stop the presentation.
Yeah. Also, for those watching, can you please let us know if you are able to see the screen share? Okay, add the screen share. Lovely.
Okay, so is everyone able to see my screen?
Yep, looks all good from my side.
Okay, fabulous. In that case, I'll just get started. So before I do get onto the presentation properly, I just want to have a bit of a disclaimer that I'm not a medical legal expert, and all of the information that I'm presenting is to the best of my knowledge. So if you need actual medical legal advice, then please you can speak to a professional or your medical defence union. But in terms of things I'm going to cover today, so I'll be talking a bit about what exactly research is, the legal and the ethical frameworks behind research. Then I'll go on to talking about research in specific groups, such as children, young adults, and adults who can't consent. And then finishing off the presentation talking about quality of research and confidentiality and data as well. So, when we talk about research ethics, I think it's important to be clear on what exactly counts as research. So, research is designed to create new and generalizable knowledge. So, this is something that goes beyond just the local setting and can be applied more widely. So, example of this is like clinical trials of new treatment, for example. In contrast, audit is a bit different, and it's about checking whether what you're doing is in line with a recognized standard and guideline. So an example of this might be, for example, if you work in A&E, looking at how many patients with suspected sepsis receive antibiotics within 1 hour as per NICE guidelines. Similar to an audit, but slightly different, is quality improvement. So this uses a structured approach, so things like a PDSA cycle, to test iterative changes with the goal of improving practice. So an example of this might be trialing a new ward round checklist. And these types of projects don't usually require ethical approval. However, with audits and quality improvements, usually they'll be overseen by a particular organization's quality improvement team. And the final one is a service evaluation. So this is evaluating how a service works without comparing it to an external standard. So an example would be asking patients if they feel that a new clinic setup is good, or just their thoughts on it. So the key thing to remember is that only research will require a research ethics committee approval. So that's the REC. So I'm going to call them RECs from here onwards. However, it doesn't mean that you can just start an audit or a QI project without any oversight. It still needs to be registered with your local governance team. So I wanted to talk briefly about research ethics and why it matters. And firstly, there are historical lessons. So some of the most infamous cases have come from unethical research. So an example is the Tuskegee syphilis study in the US, where men with syphilis were deliberately left untreated so that researchers could observe the course of the disease even after an effective treatment for syphilis was available. The other one that's a bit closer to home is the Alder Hay scandal, where children's organs were taken and stored without proper consent. And both of these cases caused an enormous amount of harm, both to those that were involved directly, but also to public trust in healthcare and research for many, many years to come. It's important to remember that even projects that feel like they might be low risk can still cause harm. And it's not just about physical risks from a drug or side effects from a procedure. Um, it can include stuff like a poorly designed survey with no could result in like a breach of confidentiality, for example, or there might be sensitive questions on a particular survey that could trigger distress. And so this is why storage of data is really, really important. And this sort of thinking isn't just for big trials, because I think there is a big line of thought that, oh, I'm not going to be involved in a big clinical trial. Why do I need to know about research ethics as a foundation doctor? But even small projects will need research ethics approval. So it's important to know about these things. And it's still evolving at the moment, actually. So there's a big drive towards AI in healthcare. And there are lots of concerns from patients about bias, lack of transparency, patients not understanding fully how their information is being used. So research ethics is something that's actively evolving, and the NHS does rely on public trust and patients volunteering to take part. So this is it's a matter that concerns research, but also like ultimately patient care. So what I'd like to do is look at some of the key legal frameworks that underpin research in the UK. So the first one is the Data Protection Act 2018, and then also GDPR. So these laws govern how we process patient data, and they are central in safeguarding confidentiality and to make sure that data is used fairly and lawfully and transparently, especially when it comes to identifiable information. The second is the Mental Capacity Act 2005. So, this is a legal framework for including patients who might not be able to consent for themselves, such as adults who lack capacity. It's not a blanket exclusion. So, adults who lack capacity can be involved in research. However, the MCA provides safeguards to protect rights and their best interests. So, an example could be a dementia study can involve patients who can't consent, but in those cases, a family member or a consultee is asked whether a patient would have been wanted to. Be involved and take part to make sure their rights are protected. But we're going to cover this in much more detail a bit later on in the presentation. Next, we've got the Human Tissues Act 2004. So, this regulates the removal, storage, and the use of human tissues and organs for research. So, if a surgical team wants to keep tumour samples for an operation for future research, then it would need to comply with the Human Tissue Act 2004. When it comes to the Rights Act 1998, so specifically Article 8, which protects the right to respect for private and family life. And then we've got the Medicines for Human Use Clinical Trials Regulations 2004. So these govern the clinical trials. Um, investigational of medicinal products. So I'm going to call them CTIMPs from here onwards. And so this is the most heavily safeguarded and the most heavily regulated form of research. And it's what we think about when we traditionally think of research. So this would involve things like if you want to test a new antibiotic in a hospital, for example, everything from the consent forms to safety monitoring must meet this legislation. And even though you might not personally be running a clinical trial as a foundation doctor, it's quite common to come across patients who are enrolled in clinical trials wherever you work. So it's worth knowing how they are regulated. And finally, you've got the Care Act 2014. So this re-established the Health Research Authority and provides the legal framework within which the recs operate. So these frameworks altogether provide the legal backbone to make sure that the research is conducted ethically and lawfully. But alongside all the laws, you've also got some key organisations that provide oversight for the research. So the ones that you'll hear about most often are firstly the HRA. So the HRA coordinates the UK research ethics system. So they run the recs, and their job is to make sure that studies are ethical and lawful. So if you're designing any sort of study with NHS patients, it will not be able to go ahead unless it's got a rec who have reviewed and approved it. Next, we've got the Medicines and Healthcare Products Regulatory Agency. So that's the MHRA. And they regulate clinical trials for the investigationals of medicinal products, so the CTIMs. And they are just making sure that the medicines or devices that are being trialed are safe and effective. So previously, the MHRA operated within the European framework for clinical trials, but post-Brexit, this is now its own standalone body in the UK with its own regulatory pathways. So, for example, if a company wants to test a new cancer drug in the UK, the MHRA must authorise this trial before you can recruit the first patient. The Human Tissue Authority enforces the Human Tissue Act 2004. So they regulate the removal, storage, and use of human organs, tissues, and body parts. So a research lab that is storing biopsy samples for future analysis must have a HTA license and comply with their codes of practice. Following that, you've got the HFEA, so Human Fertilization and Embryology Authority. So they regulate research involving human gametes and embryos. And you've also got confidentiality advisory groups. So these are an independent body that advise on confidential patient data without consent under specific regulations. And we will talk about this again a bit later in the presentation. And finally, you've got a local NHS research and development office. So once you get the HRA or the REC approval, every R&D office has to give a final green light for research at their sites. So if you've got a multinational trial that's been approved nationally, it still needs to be run past the hospital's R&D team to look for capacity and resources and governance locally before they can start recruiting patients. I just wanted to touch on the research in Northern Ireland. So, whilst UK legislation applies in Northern Ireland, there have been delays in implementing the UK's EU Withdrawal Act in 2018. So, certain EU directives and regulations can still apply in Northern Ireland. So, an example of this is the EU regulations, which are relevant to research, such as the EU Clinical Trials Regulation. So it means that clinical trial standards in Northern Ireland might differ slightly to the rest of the UK. And it's important for researchers who have patients based in Northern Ireland to be aware that there is a dual layer of regulation and that there is both UK domestic law, but also EU laws are both applicable under the protocol. Okay, so we've talked about the legal frameworks and the agencies that enforce them, but I'll speak briefly about some of the ethical frameworks as well. So first of all, we've got the Declaration of Helsinki. So this is an international statement of principles that was developed by the World Medical Association. So it's not legally binding, but it has been massively influential in terms of our modern research ethics principles, like informed consent, and this is where it all started. You've also got the good clinical practice, which is an international gold standard for clinical trials, which involve human subjects, and it focuses on two things, which is protecting participant safety and making sure that the data that is collected is reliable. You've also got the UK policy framework for health and social care research. So this has been issued by the HRA, and it sets out the responsibilities of everyone who's involved in the research, such as the researchers, NHS, sponsors. And finally, you've got GMC guidance. So this is GMC's good medical practice, and it applies to everyone who is involved within a research setting. So this still involves things like honesty, integrity, and respecting confidentiality, and that would creep into your role as a researcher as well. Finally, you've also got the four main ethical principles, which are the cornerstone of medical ethics. You've got autonomy, so that involves having valid and informed consent and making sure that participants are aware that they can withdraw from the study at any time without their care being affected in any way. Beneficence, so making sure that studies are designed to generate knowledge that benefits either the patients or the healthcare system as a whole. Non-maleficence, to make sure that risks are minimised and balanced against potential benefits. And justice, meaning that recruitment happens in a fair manner and that underserved groups are not excluded from any potential benefits. So I've talked about legislation, I've talked about the regulatory bodies, and some of the ethical principles, but how does all of this fit together? So I think you can imagine it like a flowchart. So the first thing you need to do is to identify your study type. Is it an audit? Is it service evaluation? Is it research? If it's research, you will require research ethics committee approval and review via the HRA. The other thing to be aware of is that the Research Ethic Committee is different to the clinical ethics committees. And the clinical ethics committees support clinicians who need to make difficult treatment decisions. They don't review research projects. Following that, you need to think about data considerations. Is any patient identifiable data being used? In that case, the UK GDPR or the Data Protection Act will apply, and the confidentiality advisory groups might need to be involved if it's not possible to gain consent. But then there are lots of optional bodies that might need to be involved depending on the research project. For example, if there is human tissue use, then a HTA license will need to be issued for the centre that's running it, or if it's a CTIP, the MHRA needs to approve the study before it starts. And then you need to identify a sponsor who is responsible for the oversight. So that can be a specific NHS trust or the university. And finally, you move on to the local R&D approval. So whatever your proposal is, after it's been gone through all of the other processes, is submitted to the NHS Trust R&D office for capacity and capability, and they can give a local green light. So all of the things don't necessarily need to happen in this order, but all of them need to happen before the research starts. But something to mention is that starting a clinical trial without REC approval is a criminal offence under the Medicines for Human Use Clinical Trials Regulation 2004, and providing false or misleading information similarly in a REC application is also an offence. Okay, so now that we've spoken about the general principles involving research, I wanted to talk about some specific groups of the population that might need additional or some different considerations. So the first group is research that involves children or young people. So clinical trials in children and young people are very difficult to organise, and as a result, there's a lot of off-label prescribing in the paediatric population, even though children make up about 25% of the population. So on pediatric wards, approximately 45% of prescribing is off-label, and in neonatal intensive care units, this rises to about 90%. So well-designed research is quite important to making sure there is robust evidence for safe treatments in children. So when it comes to conducting research with children and young people, there are a few things to keep in mind. So first of all, there is a dual requirement. Um, you'll need consent from a parent or a guardian, um, and where appropriate, you need assent from the child themselves. So assent isn't the same as consent. It's not legally binding. However, it is the child's willing agreement, and it should always be respected and sought. Um, and this makes sure that when children or young people are involved, it's voluntary, and information is given in a way that's appropriate to the child's age. Um, and recognizing that even very young children can show refusal non-verbally. For example, they might turn away or they might become distressed. And to support all of this, child-friendly information such as an age-specific participate information sheet should be provided, and that would have been reviewed by a rec whilst they were getting approval. In terms of the risk threshold, research involving children should be considered low risk and should offer either a direct benefit to the child or to the wider society. And importantly, children have the right to dissent. So even if a parent has consented, if the child refuses, then the refusal must be honoured. And all of this must be documented in quite a thorough manner. So the fact that the parent or the guardian has consented, and they give fully informed consent, um, and the fact that there is a safeguarding plan in place if the children or young people um, experience any distress or there are any concerns throughout the study. So I've got a scenario here. So, an 8-year-old has initially assented to take part of a research study on asthma inhalers. However, on the day of the data collection, the child is distressed and is refusing to complete the study questionnaire. What is the next most appropriate step? So, I'll give everyone probably 20 seconds to read through the options, comment down below. Okay, so correct answer is to respect the child's dissent and withdraw them from the study. So I think this really highlights the fact that consent and assent is not a one-off, it's an ongoing process. And it's important to check for willingness throughout the study. Um, as children and young people become older, and become adolescent, Gillick competence becomes more important as they grow into their decision making capacity. And this has been covered extensively in some of the other lectures. So I won't talk about it in too much detail here, but being aware that some children, and checking for Gillick competence. Okay, so the next group I want to talk about is adults who lack capacity. And for this population, there are strict safeguards under the Mental Capacity Act 2005. So similar to the research for children and young adults, the research has to be directly relevant to them. It should relate to the condition which is affecting their capacity or its treatment. And it should be not feasible to do the study on people who lack capacity. Um, Before these patients are involved, it's important to have a personal or a
Hello, Aditi. Okay, so sorry about that. It looks as if Aditi's internet may have cut out. She's just suddenly disconnected. So sit tight. Let me try and sort out what's going on at the moment. There we go. Helen? Hello, Aditi? If anyone else is watching, would you be able to comment whether you can either hear me or Aditi? Yes, sorry about the delay. I'm just trying to sort it out on my phone. So I'm going to turn off my video camera. Yeah, sorry about that. But if you guys hold tight, we should be back in a few minutes. Thank you, Mahan. Thank you, Jennifer. All right.
Hi, can you hear me?
There we go. Yeah. Okay. So sorry everyone about that.
Sorry about I didn't
Lovely.
listen there.
No, all good. Everyone's still hanging on, so we
Okay,
can
what was
take a.
the last thing that everyone heard?
So for me, it was adult and mental capacity. I'm not sure
Okay,
what it was
fine.
for everyone else.
Okay, well, I can just start from that section again.
Yeah,
I
of
didn't get
course.
that much
I'm,
further in.
yeah, of course. I mean, it doesn't matter too much if we overlap a little
Mhm.
bit. Lovely.
Okay,
Well,
fine.
good to have you back.
Right, okay, I will, reshare my screen.
Lovely.
Can everyone see
Perfect.
my screen okay? And can everyone hear me?
Yeah, if there are any issues, please post in the YouTube comments.
Oh, fab. Okay, cool. I will just continue from this slide really. So what I was talking about was basically um, respecting what the patient's likely wishes and thoughts would have been when it comes to involving adults who no longer have capacity and are being involved in research. Um, Yep. I was then going on to talk about special provisions for emergency situations. So, for example, if there is a trial, like one example that I can think of is if there's an anaphylaxis, for example, to a medication that was tried. Um, there is a special regulation where urgent treatment that is required can be given if the patient lacks capacity. Um, so, in these sort of situations, the legal representative doesn't need to be consulted if the treatment is required urgently, if the nature of the trial requires urgent action to be taken, it is not reasonably practicable to obtain consent in time, and the Research Ethics Committee has already approved that procedure under which the action is being taken. Um, but the same as with children and young adults, um, we must try and respect the patient's right to object. So even if they've got passive signs of distress with or showing any sort of not wanting to participate, then they should be withdrawn from participation. It's also important to emphasize to their personal or their nominated consultee that they have the right to withdraw the patient from the trial. Capacity can also fluctuate. So if in any particular example, a participant regains capacity, um, then they should give their own informed consent in order to continue with the trial. Okay, so I've got another scenario here. Um, so a patient with dementia who lives in a care home is enrolled in a study on reminiscence therapy. Her son is acting as the consultee. The patient is often confused, withdrawn, and disengaged during these sessions. What are the key ethical considerations in continuing her participation in the study? So I'll give everyone about 20 to 30 seconds to put anything in the chat. Okay, so the first thing to be aware of is ongoing assent. So even if the consultee has agreed to have the patient be involved in the study, the patient's current willingness and their current distress must guide participation. And distress can manifest in lots of different ways, but it can include withdrawal, confusion, or discomfort. And if they display any of these signs, then that should trigger some sort of reassessment. Um, the consultee's decisions should reflect the patient's likely wishes and welfare, not just the study objectives. And they should be made aware that they can withdraw at any time. But also the idea of minimization of harm to make sure that any interventions that are happening are not exacerbating the patient's confusion or their anxiety. Okay, so I'm going to move on to talking about confidentiality and data. So, the first main thing is informed consent in research. And this is one of the key principles that participation within a research study should be voluntary and fully informed. So that is, they should not be coerced into participation. The information that must be given to them should be clear and jargon free. And the consent should be specific to that one study. It's not a sort of blanket agreement to future or unspecified research. Um, there are some core elements that need to be covered when it comes to gaining informed consent. So that involves the purpose of the study, potential risks, potential benefits, what data is going to be collected, how it will be used or published, and the right to withdraw. And the level of information that should be provided should meet the standard of what a reasonable participant would want to know. And this draws upon the same principle set out in the Montgomery versus Lanarkshire Health Board case. So I'll discuss that in just a second. Um, but yeah, main thing is patients should be told about how their data will be stored, protected, shared, but also how they can withdraw. as well. So one of the landmark cases in medical ethics was the Montgomery versus Lanarkshire Healthcare Board, and this involved a woman with diabetes and small stature whose baby suffered from a serious injury during birth. So I think she had a vaginal delivery, and she was warned that she argued that she hadn't been warned about the higher risk of shoulder dystocia, and if she had known, she would have gone for a C-section instead. So this went to the Supreme Court and they ruled that doctors should inform patients of any material risks or any reasonable alternatives. And what counts as material is judged from the perspective of a reasonable patient. So that involves what's known about the patient's values and their concerns rather than what the doctors deem to be important. And this ruling transformed consent from a doctor patient model to a more of a shared decision making. So, in the context of research, this means that information should be tailored to an individual's concerns, especially when it comes to risks, data use, and long term implications. And all of these things will matter differently to different people. Okay. So I wanted to talk briefly as well about using identifiable data without consent. So this is very much an exception, and this is not the norm. Consent is the gold standard, really. But you can use identifiable data without consent if the data cannot be anonymized. The consent is genuinely impracticable. So, for example, if you cannot trace the participants or there is a very large or a historical data set, it's not just to do with convenience, it has to be you are unable to get consent in these situations, and the research needs to be of public interest. And in these cases, the HRA's confidentially advisory group will review this. And documentation will be needed into why consent was not possible and how risks will be minimized. The principle of data minimization, again, is still very important. So even when you're using identifiable data without consent, only collecting and using the minimum amount of necessary data to answer the research question. And it also comes into transparency. So there might be a public notification via a website or a leaflet to inform patients and the public, especially if consent isn't feasible. And this brings us on nicely to safeguarding patient data. Um, So in research, it's preferable to use anonymized or pseudo-anonymized data. So the difference is that anonymous data means that the individual cannot be identified at all, whereas pseudo-anonymous data has some of the identifiers replaced, but someone who has the key could re-identify that patient. So it's important to identify when having identifiable patient information is properly necessary, and only collecting what you need for your research questions. Um, then it's to use something called honest brokers and safe havens. So, honest brokers are intermediaries who manage identifiable data securely, and safe havens are secure systems that allow data analysis without exposing the patient's identity. So, making sure that data is encrypted, password protected, stored on a secure server, and there should be a log of who is able to access the data and for what purpose. Okay. And finally, I just want to talk about good practice within research. So, when conducting research, it's important to uphold the integrity and quality of what's being done. And there are some key principles there. So, first is having an accurate and detailed documentation of the protocols, the consent forms, and everything that was used, but also publishing all results, not just positive results. Negative results are quite key when it comes to preventing repetition of research, but also helps to contribute to a complete evidence base. Thirdly, is the protection of patient identity, and any data that's presented in a publication or in an oral presentation, for example, should be anonymised. And fourthly is the reporting of misconduct. So there's lots of different types of research misconduct. So it can involve stuff like fabrication, so making up results, falsification, which is manipulating the research material or the equipment, or plagiarism, which is using someone else's ideas or words without credit. And there are a few oversight bodies who look over and monitor for misconduct. So first is the Committee of Publication Ethics, and they provide guidance for journals and researchers to maintain publication integrity. You've also got the UKRIO, the UK Research Integrity Office, who provides support and advice promotes the best practice in when it comes to actually conducting research. And finally, institutions also have a role to play, such as an individual university or an individual NHS trust have a duty to investigate any misconduct and to maintain ethical standards and make sure that they're being followed. So, to summarize, when it comes to special patient populations, making sure that both assent and consent are gained. Participation in trials must be voluntary and fully informed. To minimise data collection and anonymise where possible. And to maintain a detailed and accurate record of protocols, consent, data collection, analysis. Okay, and I've got a list of all of the references. So this is legislation. These were the other references that I used. Okay, so that's the end of my presentation. I'm happy to take any questions.
Well, lovely, Aditi. Thank you very much for the webinar and the presentation. So yeah, if you have any questions, please leave them in the comment section in YouTube Live. Also, please feel free to fill out the feedback form that will be on the left corner, top corner of your screens. But no, thank you very much for a very in-depth, actually. I mean, all the legal frameworks covered, ethical frameworks covered, and so on. Very useful to provide a foundation to research ethics, of which not many people are accustomed to, despite, I mean, many of you watching would have gone through an audit department or may have even produced papers and would generally need to write a research section. A sort of conflict of interest research declaration section. One interesting thing I'd like to add, actually, that I actually forgot to mention to you, Aditi, the anonymized data bit, something that I found quite interesting in the past is anonymized doesn't necessarily just mean getting rid of the name. So you actually have to be relatively aware when your sample sizes are quite small and you're investigating or looking into pathology that is quite rare, in the sense that if you have people that can be identified solely due to patient demographics as well as pathology, that actually isn't anonymized despite not putting their names in. Mm-hmm. So that's actually protected under GDPR. And there have been people who've been caught out on it in the past. It's incredibly rare, but something to note. But no, thank you very much, Aditi.
Thank you.
So far, don't have any questions. So we'll give it another 30 seconds. But otherwise, those of you who joined late, this will be put up on the YouTube section on Mind the Bleep, so please feel free to watch it then and let others know as well. So the next session will be on safeguarding. That I'd have to remind myself, it's either next week or the week after. But it would be nice to see some of you guys there then. Okay, but no, this is the last session that Aditi will be joining us for. So very much appreciate the last 3 weeks the last 3 months for which she's contributed to the Mind the Bleep Medicolegal webinar series. So thank you very much.
Thank you so much for having me.
Of course. I hope it's been enjoyable, and I hope it's been enjoyable for the rest of the viewers as well. Anyway, doesn't look like there are any questions, so thank you very much and Have a good night, everyone.
Thank you everyone for coming.